Pauline Norris is from the University of Otago. She's a sociologist. She's a research professor. She's research professor at Biototai Centre for Pacific Health. And her main area of research is access to medicines, but she has a long-standing interest in how data are produced and how this affects data completeness and quality. And this led to her the Marsden-funded project, which she's going to present.
Great, thank you so much. So kia ora koutou, my name's Pauline Norris, and I'm going to talk about interRAI assessments and action lessons for data analysis. And as Bridget said, this is a Marsden-funded project, and this is the list of the colleagues working with me on the project. We have the next slide, please. So administrative data, when we talk about administrative data, we're talking about data that's produced as a sort of byproduct of the routine operations of government. And in this case, government includes healthcare as well. So every time you register your car or get a speeding ticket or are admitted to hospital or pay your income tax or pick up a medicine from a pharmacy, there's a record of that generated, and that goes into a data set which we describe as administrative data. And administrative data is obviously really important for improving policy and practice, as the speakers before me have alluded to. But there are well-known threats to the validity and the reliability of this data. And I remember when I was a student, which was a long time ago now, being taught about using administrative data and being taught that you should be aware of how the data is produced and the kind of the incentives of the people producing it. So this is not a new story, but I think it's a much more important story now because since I was at university, since I was a student, we have much more powerful computers, and we now have AI. So we can use this data, we can analyze it and use it for not just for describing and analyzing, but also for predicting. So this is a kind of a new age of the amount of data. So now we talk about big data, and the ways in which that data can be used are changing. And so it's even more important, we think, now to think about how data are produced and how this affects its validity and reliability and completeness. So aspects of its quality. Can we have the next slide, please? So the aim of our project was to explore the production of this big data through looking at 2 case studies. So the case studies that we chose were notifications to child protection and interRAI assessments. So I wanted to say that because I wanted to emphasize that we're not sort of like singling out interRAI for any reason. We just think it's an interesting example of this bigger question of how is big data actually produced. And I also wanted to say nothing that we say is about whether interRAI is a valid way of assessing older adults. Obviously, there's lots of research that shows that it's really useful. What I'm talking about is when the data is used for research. And often when the data is used for research, it's like one data point or a small number of data points that are used. Whereas for an interRAI assessment, for making a needs assessment of an older person, then you're using lots and lots of data points to make up a care plan. And so obviously that's a perfectly valid and reasonable thing to do. We just want to focus on you thinking of interRAI as data that goes into this big integrated data infrastructure that the government runs. Can we have the next slide, please? So we did a qualitative case study. The data collection was in 2022 and 2023. Was in 3 different regions of New Zealand. We did 28 interviews with 31 participants, most of whom did needs assessments as part of their job. but we also had some other people who represented other perspectives on the interRAI. And we did 15 observations of interRAI assessments and talked to staff before and after those. Next slide, please. So I want to talk about the results, and it's sort of two aspects of the results. So I want to talk about data completeness and representativeness, and then talk about validity and reliability. So for many of the researchers in the audience, this will not be new at all, but I really wanted to, I guess, draw attention to the need to think about these limitations, especially for researchers who are not familiar with aged care. So the first thing in terms of data representativeness is that there's a non-random group of people who are less likely to be assessed. So there'll always be people who are not represented in a data set, but there are particular issues if that group are not randomly selected. So there are barriers to accessing GP care. People who speak a different language, or have a different culture, or have other communication issues with GPs and other services might be less likely to get an interRAI assessment. So there are these barriers kind of like mean that people are less likely to be referred to an assessment service and have an interRAI assessment. We also really noticed the importance of advocacy from whānau in getting an assessment. So we think that people who don't have whānau who are physically around, or who are not inclined to advocate for them, or who themselves don't have very good skills and resources in terms of advocating for health service, might be less likely to have an interRAI assessment. And there's a really noticeable lack of accessible information for the community about the needs assessment process, especially in languages other than English. But actually, none of the whānau we talked to really had any understanding of how the system worked when they first started to notice that the older person they were supporting was needing some help. So there's a big lack of information. People so I guess what we're saying is that people who are poorer, people who maybe Maori or Pacific, or from other cultural groups, or who don't have whānau around to support them, might be much less likely to be assessed. So at any given level of need, they're less likely to have an assessment than other people. So in terms of the data, what that means is that when you're looking at a data set, you are not looking at a population of people all at the same level of need. So some of the people with the same level of need will not be represented in that data set. Can we have the next slide, please? In terms of validity and reliability, one really clear thing that we found was that we noticed was how highly skilled needs assessors are. So we've got a report that's coming out soon, and we wrote a lot about the different skills that we saw needs assessors demonstrating, and they were really, really impressive. But it also has to be said that assessment is a highly complex task. And needs assessors need to have the time and resources to be able to do assessments in a reliable in such a way that you get valid and reliable data. So the needs assessors are often working in a situation where the data that they can get from any one source is incomplete, or sources might be conflicting. So what, for example, the families say about the person may be different from what the person themselves is reporting. It seems to be important about who attends the assessment. If, for example, there's an older person with some cognitive impairment who is being assessed by themselves, it's much more difficult for the assessor to reach conclusions about what's actually going on. people use really colloquial, older people use a lot of colloquial expressions when answering questions. And as someone I think was mentioning before when in Bill's presentation about loneliness, like loneliness is actually, it's a subjective phenomenon, and it's quite a complex phenomenon as well. And it can vary over time. So it's always going to be really, really difficult turning difficult, subjective, complex phenomenon into a measure, yes or no, or a degree of something. So just a brief example of that. So one needs assessor asked a patient how to rate his health, and he said, "I've had a good innings," and I thought that's like that expressed a lot, but it didn't actually answer the question. And obviously, she followed up with other questions. But that's the kind of thing I mean about that. Sometimes people think about like what they would expect at their age. So it's not just how their health is, but it's how their health is compared to what they would expect at the age that they are. And also, obviously, for some people, there's hearing impairments. For some people, there's cognitive impairments that make communication difficult. And I think the other thing that was really clear is that often participants in the needs assessment process have an agenda, and they also have differing understandings about what the assessor, who the assessor is, and what's actually happening. So, for example, one of our participants who works with Asian older people said that, like, for Asian people, they often see the assessor as like an official person who you should defer to and have a lot of respect for. And so that makes it difficult for people to express the truth of what's going on for them. And obviously, in some situations, the older person or the whānau maybe really want to be eligible for age residential care. Sometimes they want to avoid that, and sometimes the older person and their whānau might have different agendas as well. And also, I think another kind of agenda is that often the whānau felt they didn't want to say too much in front of the older person. They wanted to protect the older person's mana by not saying actually what the real situation is or how much help they're needing to give to the older person. So all of these things mean that these are not just sort of straightforward objective measures of a phenomenon. They're kind of socially negotiated, socially produced measurements out of a really complex situation. So can we hit the next slide, please? So I just wanted to briefly talk about, or I guess to re-emphasize that we're not kind of singling out the interRAI. The other case study that we used in this, that was part of the study, was looking at notifications to the child protection system. So this is when people ring up or contact Oranga Tamariki and say that they think there's something bad going on for a child, abuse or neglect or something. And so there were really interesting organisational and individual variations there in how people decided to make that notification. So again, we're looking at the data set of notifications of potential child harm and thinking about, does this actually represent the universe of child harm? And so for some people in some organisations, they had kind of like given up reporting a lot of potential harm because they'd contacted Oranga Tamariki about harm and nothing was done. So it had kind of fallen below the threshold of concern for Oranga Tamariki. So for some people, the fact that nothing happened meant that they gave up notifying those kinds of concerns. But other people, the fact that nothing had happened actually made them report more. So they were kind of like thinking, well, if I kind of bombard Oranga Tamariki with reports about this, then it's more likely to be taken seriously. So again, you might get two children in the same situation, but one of them is much more likely to be reported than another, just depending on who they come in contact with and which organisations are surrounding them. Another data set that I know really, really well, which is the pharmaceutical, it's called the PharMS data, and it's the all dispensed, it's a record of all dispensed medicines.
5 minutes, Pauline.
Cool, I'm nearly done. I first started working with the PharMS data set in 1993. And I thought I knew everything about it. And actually, I only just found out in the last year or two that actually there's a lot of data in there about medicines that are prepared for dispensing but are not actually picked up by people. So I think this just goes to show that you can think that you know a data set really well, but actually there are aspects of how that data is produced that you don't necessarily know about unless you really, really try hard to find out. Another example, I had a PhD student who was looking at self-poisoning presentations to emergency departments, and she wrote about how clinicians have to make decisions about whether something is a poisoning, but even more difficult, they have to work out what the level of intention is and how difficult it is to work out the difference between a sort of a careless accident and a kind of an intentional act, and how that affects and how things like the demographics of the person might affect the decisions that clinicians make about whether they think it was intentional or not. And then just lastly, I've been working with a colleague looking at staffing and workload models for allied health in hospitals, and there were things like so this was people recording, staff recording what they'd been doing. But when they were really, really busy, they didn't get time to record what they were doing. So it looked like they weren't busy, but actually it was because they were so busy they didn't have time to record that. So can we move on to the next slide, please? So the point I'm making is that, as with other administrative data, it's really important to understand how interRAI data are collected to ensure that we make accurate conclusions, that we draw accurate conclusions from it. And I think that we all probably know that, but I think it's particularly a risk when interRAI data and other administrative data are used by people who have no background in the area. So we all have some connection with older people's health, and so we would have some idea about how the interRAI data are collected. But now that it's part of the integrated data infrastructure, it can be used by researchers who have absolutely no idea about how it's collected, and they might think that each measurement is just a simple objective measurement of the truth and not understand that actually these things are produced in a context. So I can't remember whether there is a next slide. I think that's the end. Just a couple of references about the other data sets that I talked about, and then our report that's coming out in the next couple of weeks, which I can email the link out to people.
Thanks very much, Pauline.
Thank you.
So now to questions. People have questions? I have a question, Pauline. Those of us in the business know that interRAI assessors do a very, it's a complicated task. Did you find that the assessors themselves were aware of how much expertise was involved when they were completing those assessments?
I think they had some ideas about it, but I suspect that a lot of the skills that they have like they've developed them and honed them so much. They're just kind of second nature. They definitely were good at telling us like some of the things that are really difficult, like that you go into a situation and you read some notes about the person and maybe about the family, but you actually have no idea what's going on. You walk into a situation where there might be lots of conflict going on, and you are just kind of, yeah, it's like you have to chair a meeting with people and you've never met them before, and they may all like there may be kind of long-standing conflicts between them. And we certainly witness things where, for example, where the needs assessor would ask a question and that would kind of prompt a long story in response, and just trying to keep it back on track, but also allowing the person the chance to express themselves. They were really, really impressive. It was really amazing watching the assessments.
Good to hear. Thank you. Any other question from anybody?